Hello, everyone. I'm Renxin Ping from Regional Hospital, ultrasound department. My presentation is about a confusion liver mass, and this case is an interesting one. This is an old male patient. He came to our hospital for routine physical examination. When we reviewed the medical history, he had hypertension, type 2 diabetes, fatty liver, coronary heart disease, no other chronic disease, no heavy drinking or smoking. The serological and tumor indicators were negative. Conventional ultrasound showed that he had fatty livers and a hypoechoic liver nodule. Maybe it was a focal fatty spring or a neoplasm. So we recommended the patient to undertake a follow-up in 3 months, or additional examination were recommended. 3 months later, the patients come to the hospital for another CT scans. The results show that maybe it was a hemangioma, because we can see hyperenhancement in arterial phase and continuous hyperenhancement in portal venous phase and lateral phase. Because of the size of the nodule has increased slightly, we recommend the patient to undertake a conventional ultrasound. The results confirmed our suspicion. The nodule has increased from 12 millimeter to 18 millimeter. So contrast enhanced ultrasound were recommended. We see that the nodule have faster hyperenhancement in arterial phase and mild washout in late phase. So we diagnosis this nodule. Maybe it was a malignant tumor, and additional MRI scans were needed for the diagnosis. According to the MRI scans, maybe it was a benign nodule, because we see that the hyperenhancement in arterial phase and no washout in late phase. And the radiologist suggested the patients to undertake a follow-up regularly. In the following time, several months, the patients undertake the screen and surveillance using conventional ultrasound, but the nodule is growing larger and larger. And finally, he came to our liver tumor MDT team for further diagnosis. We recommend the patient to undertake contrast and enhanced ultrasound. And we see that the nodule become larger, and we see hyperenhancement in arterial phase and mild washout in late phase. And the starting time of washing out time is earlier than several years ago. So we diagnose these patients as malignant tumor and recommend patients to undertake biopsy. And we get 3 samples of the liver tumors under ultrasound biopsy, but the result showed no evidence of malignancy. And in the following several months, he used a conventional ultrasound and MRI scans, and we see that the last MRI scans findings were similar to the previous MRI scans. But with the increase in the size, MRI diagnoses nodule as malignant tumor, and he undertake biopsy. The final result shows that he suffered from hepatocellular carcinoma. Actually, this patient was a retired professor. He came from infectious disease department of our hospital. He himself was an expert in liver disease. Because he had no history of hepatitis B or C, he just couldn't believe he had the chance to have the hepatocellular carcinoma, and he refused to undertake any surgical treatment until he was diagnosis with biopsy. Though most of the hepatocellular carcinoma in China was developed from hepatitis B related cirrhosis or fibrosis. Now, non-alcoholic fatty liver disease has become worldwide health problems, especially in Asia countries. Now, neighborhood-related or NASH-related cirrhosis or fibrosis may have a high risk for HCC. Contrast enhanced ultrasound is strongly recommended by guidelines, and the agent we used is pure blood pool agent. Maybe it is a good complementary to other imaging methods in the characterization of focal lesions. That's all. Thank you.
Thanks, Dr.任新平, for your presentation. Now we would like to have Dr. Tang Shaoshan to comment, please.
Thank you. Thanks, Dr.任新平. You give us a good presentation, which records the whole development process of this lesion. As we know, it's a rare case that HCC occurred in the non-alcoholic fatty liver disease. In general, the pathogeny of HCC include virus hepatitis, main cause in our country, and alcoholic cirrhosis also include non-alcoholic fatty liver disease, as you present for us and others. You know, recording the study, 3 in 10,000 no alcohol fatty liver disease could convert to HCC. And would you ask your question? Could you give me some advice or your opinion? What are the influence factors of washout for HCC on CUS?
Thank you for your question. As we know, arterial phase enhancement is very important, especially with special enhancement patterns. And the washout is also very important. Maybe some hemangioma or focal nodular hyperplasia may have washout in later phase, especially in patients with fatty liver. And but for some high-grade hepatocellular carcinoma, maybe they have no washout. So we need to combine with medical history and to give the right diagnosis. Thank you.
Thank you. My question is for HCC. As we know, the calcification degrees and the size of the CC, the washout time is quite different. You know, the size.
Nodule size.
Yes, and yes. Calcification degrees of HCC.
The larger the nodule, maybe the degree of washout is serious, is obvious.
Anyway, thank you. It's a very good presentation. Thank you very much.
Thank you.